Welcome. Today we have Diane Parham with us, who is a professor in the Department of Pediatrics and in the School of Medicine at the University of New Mexico. She teaches and does her research in the Occupational Therapy Graduate Program at the university, she is a well-renowned individual in the field of sensory integration as relates to children with developmental, behavioral, and learning difficulties. She's also a co-author of the upcoming new scale or revised scale of the Sensory Processing Measure 2. And we're fortunate enough to have her here today to talk about the new scale and about conducting comprehensive assessment in sensory integration and sensory processing. So welcome, Dr. Parham.
Well, thank you so much. And it's really a privilege to be doing this. I appreciate being invited. So thanks very much. And it's fun too.
Absolutely, yeah. Terrific.
Yes, and I love talking about this stuff. So
as do I. And I'm really excited about the revisions to the SPM2. I mean, I loved the first version. So I'm really eager to hear about what's new, what we can look forward to, when we can look forward to having it, all of those good things. So would you tell us a little bit about it?
Sure. Well, for those of you who are already familiar with the original SPM, sensory processing measure, there were two age groups, and I can't remember how long. Well, I think the first edition was 2007, I believe.
Mm-hmm. I know that
yes.
The article came out about the reliability and validity was 2007.
Yeah. So that might be what I'm thinking of. So the age groups were preschool and school age. So 2 to 5-year-olds and then 5 to 12-year-olds. And the questions were different for those particular age groups. And what was a little bit unique, I think, at the time when these were first published is that there was an option where you could collect data from just a parent or primary caregiver at home in the child's everyday living situation. And an additional option was the preschool or elementary school teacher. So you could separately collect these forms, and the questions were a little different for the adult at home who is the caregiver versus the adult in a school setting.
Right.
And so we wanted this to be friendly to practitioners who were working in school settings where it might be actually a little bit more practical to have that teacher form. And then we also wanted to have that home form for those who are working with parents directly, maybe in a private practice or medical type of a practice group. And an idea that actually the publisher came up with was, hey, we could look at whether those adults, if you collected data as a practitioner, did an eval and had both the parent and the teacher forms, you could also compare what's going on in that environment and how the child's functioning in that environment.
Right, and I think that was one of the features that I really loved about your original scale, because it's so often that a family comes to even our clinic and says, well, the teacher says that these kinds of problems exist, but I don't see those at home. And instead at home, we have different things going on. And it really speaks to the importance of context within a comprehensive assessment.
Oh, absolutely. And one of the things I emphasize to practitioners who are going to be using that feature of the SPM, where you're looking at, is there a significant difference? And by the way, it's based on normative data. Because there's always a difference between parents and teachers. They're never going to say exactly the same thing. But how big is that difference? And is it a large enough difference that it actually is a meaningful difference? And you ought to, evaluate a little further, dig a little further. I would say definitely go, if at all possible, visit the actual context of the classroom and or the home. And talk to the adults there, because it's, as you just said, it's the context is so powerful. And I emphasize, especially when I'm teaching my students or maybe new therapists, I warn, don't fall into the trap of thinking that one person's right and the other one's wrong. Right. Like the parent's right and the teacher's wrong, or the reverse. it's a matter of context. They're both telling you what's happening in that context.
Yes.
So they're both right in terms of describing what's happening. And your job is to be somewhat of a detective in figuring out what's happening and what are the contextual features that are contributing to this significant difference.
Yeah,
That
and
may be going
and it
on.
really is consistent,
So
I think, with the, the world of diagnostic practices across even mental health conditions, that you want multiple sources of data to inform, because even with those two informants, then you also have the clinician who's going to interact with that child and make determinations about what sensory features might be interfering with function, and creating hypotheses around, each of those situations.
yeah, absolutely. Yeah. So with the SPM too, we're continuing to have those same age groups as in the original one, but what's different is we've just expanded greatly the age range.
Yeah.
So yeah, so that's been interesting. It took us actually, I think it was at least a couple of years to even generate the questions, because there are 5 of us who are authors. We had these long conference calls, sometimes, oftentimes a couple of times a week. And we would argue,
Oh, I
we really
bet.
argued, oh yeah, about what's essential to include. So we
So
have,
what's the youngest, and tell me about the age ranges.
okay, great. So the youngest is at 4 months.
Mm-hmm.
4 to 7 months is the frame, and we've got questions for that. And of course, for older infants, they change so rapidly. We had to create a different set of questions for the what is it? I'm looking at my cheat sheet here. The 10 to 30 months. So it's 4 to 9 months,
Mm-hmm.
and then 10 to 30 months. A big difference in those two ages.
And that's there is nothing really like that out there for that really younger population that can oftentimes be very vulnerable, and oftentimes we can see
Yes.
those behaviors early on, right? Especially those
Yes.
clinicians who are working in early intervention.
Yes, that's right. Oh, so we're so excited to be working, having this tool that early interventionists can use, and I know I'll be learning a lot from what they're finding out.
Yes, well,
so.
that is really a source of data. I mean, as we were talking about just earlier, that to be able to determine in different populations, in at-risk infants, what are the early features that could be predictors of later challenges in preschool or school age.
Yes, these tools are going to be great for longitudinal research, which I've done before. It's hard to do it. It's because you have to, very hard, because you have to come back and find the people and then hope that they're going to be willing to participate in it again, right? So actually with a questionnaire, it's not as difficult as
right. At least they don't have to get up and come to your office, right?
That's right. That's right. You can mail it. Or electronically with the SPM, the current as well as the new ones. You can have an option of a paper form. A lot of people like paper. I do myself. Or you can have it completely electronically and be entering on a computer. And a parent could do that.
And then it comes back scored when they enter electronically to the clinician?
Yes.
Okay.
Yes. Yeah. It is scored and graphed. Mm-hmm. As well. So that's a very nice feature. Well, and another option too that's there is, and there are some pros and cons to this, and that is that Diana Henry, one of the 5 authors, developed something called Quick Tips, and it links specific items to strategies that the therapist might consider suggesting to the parent or teacher. So the thing is that I feel strongly actually to use the SPM, just the basic part of it, you really do need to have post-professional training, past your occupational therapy, basic entry-level degree, whether that's a master's or a doctoral degree now, you still need to have, if you're going to really work with this sensory stuff, right, with sensory issues, it really is ideal to be able to get the additional training in that specialty area.
Right. No, I don't disagree with you at all. I do want to come back to this because I do think it's important for you to help us understand how the SPM two will fit into a comprehensive assessment, what the other tools are that we
Absolutely.
want to do. But I don't want to let go of knowing what all the age groups are.
Forms are. Yes, okay, let's get
30 months.
let's get back. Okay, let's go back to that then. Okay, so we've got now we have the infants and toddlers. So that goes up to 4 to 9 months and then 10 to 30 months. And by the way, it's you have the caregiver report. You can have an alternative caregiver also fill it out. So it could be two parents, or it could be a nanny, a live-in caregiver, or a babysitter. So it's possible to use that with more than one informant.
Right. And is there any criteria around how long that other alternative individual has to be associated with the child? I mean, like, do you expect them to know the child for at least a minimum of 6 months or a year, or?
Yes, and how many hours per week? And off the top of my head, I don't have it memorized, honestly, but I know that there was a big discussion of that, and there are those criteria, yes, that it has to be more than just a few hours a week, too.
Right, because I've been involved in some studies with children who are in foster care and group homes. And the interesting thing about that is, would an informant from a group home qualify? Because those are the only people on site who are interacting with those kiddos to give accurate feedback. What would be the minimum amount of time that they will have had to have been living in that environment for that person to be sort of qualified to make those determinations?
Yes. Yeah, it really is an important point.
Yeah.
Because you really do have to sort of intimately know what the patterns are in the person's behavior.
Right.
Yeah.
And yet, I think that, being able to rely on a nanny when you have working parents is really a great feature too, because sometimes that is the person who's on the front line with the child and going to the therapy sessions too.
That's right. Yeah. So it is important to identify who those critical people are in this child's life.
Right.
Absolutely. So I think I mentioned earlier that we have the same preschool and school age ranges as the originals. That's 2 to 5 years old and then 5 to 12-year-olds. Actually, with each of these, there's overlap in the top age with the lowest age of the next form up.
Mm-hmm.
Okay, so for example, the infant goes up to 10 to 30 months. Preschool starts at 2 to 5 years, that's 24 months. So there's an overlap. So the practitioner has the choice. I could use with a 2-year-old, I could use the preschool version, or I could use the older infant version.
Mm-hmm.
Okay, so what to think about there is the preschool version. We're sort of thinking about children who are in full day programs there. So I would, if the child's at home full time, I would take the infant. I would choose the infant form.
Right. That makes a lot of sense. Yeah.
Yeah. Okay. And so then for adolescent, so these are entirely new forms. And wow, that was something coming up with questions for adolescents, a different thing altogether.
Yeah.
And then we have self-report. Okay, so at this age, we introduce a self-report form and a primary caregiver form, and also a teacher form, someone at school who knows the child well. So that age range is 12 to 21.
Mm-hmm.
And then adult overlaps a couple of years, 18 up to 89.
Wow.
Through 89. Of course, a lot of people are living quite a bit older than 89, but I think it's safe to say they could use the adult form.
Yeah, I think so. And also because I think that there's an increasing awareness, right, in geriatric practices that that these are adults who are going to be facing more sensory impairments in later years that they may not have experienced actually in their youth.
Yes, the data are still being analyzed, by the way, but this surprised me initially, and I don't know if this is going to hold true when we have the final normative data analyses done.
Right.
But initially, it looked like there weren't significant differences across that huge age range. And I thought for sure there would be.
Hmm.
And it didn't come out initially. So we'll have to wait and see how the final norms come out, from that range of 18 to 89.
Right.
But the
Right. Well,
initial examination didn't show that.
interesting. Yeah. I mean, I guess there is that perspective. And I'm not sure when I learned this or how I did, but that there, some of these sensory features plateau, right? I mean, that they're, yes, we see changes across development, childhood development, but that in adulthood, it's sort of reached the certain consistency and level of
Yes.
manifestation.
Yes. And it could also be that, and I don't think this is another explanation. I don't think it contradicts actually what you're saying, but it could sort of fit hand in glove, is that as an adult, you sort of crystallize your views of yourself. I like this and I don't like that. And yes, I'm a person who would do these things. And it becomes part of your identity,
Yeah.
actually.
Yeah, that's so true.
Your sensory responses become part of that.
Yes, yeah. And as we
So
get
that
older,
may be.
we get more entrenched in those patterns of behavior, right?
It happens, yes. Yes, it does.
But so a couple of things I wanted to follow up on, though. What I really like is the idea for the adolescent group that that you have both parent and self-report, because I think it is an emerging time, obviously, for self-awareness in the individual themselves as they go through, puberty through to adulthood, so to speak, or young adulthood, and also how the two perspectives match up. Because in our clinic, when we've seen adolescents and young adults, there's oftentimes there are two different kinds of situations. One where the individual, the young adult, knows that something's just not been working right in their life, and they welcome the opportunity to engage in, an occupational therapy intervention. And then there are others who are sort of dragged there a little bit more by a parent who says, I'm tired of seeing you struggle. I want you to get help. And they're like, I don't need that help. And I think being able to bring that adolescent on board to set the stage for a dialogue with you as a clinician and the two participants, the parent and the youth, to talk about those differences and why a parent might say, I'm seeing you struggling here, and the kid's like, no, I'm not, I'm fine.
Yes.
And they could both grow in awareness and a shared experience around the sensory components of each of their daily lives, really.
Yes, yes, absolutely. And actually, I want to bring up a couple of points. And one is that, just building on what you were just saying, I think the best use of the SPM instruments is when you're using it as a structure for conversation. So we do have people initially fill it out on their own without going over item by item, just if they're able to read.
Yes.
Then they fill it out. And then it's ideal if you have that time to sit down and really discuss it. And the point you're making about how this could be a springboard for discussion, say between an adolescent and their parent, okay, the same could be applied to adults. Okay, so you could have an adult and then the partner of the adult rating that person.
And would the partner of the adult fill it out on their, let's say, their companion, or they fill it out on themselves and they talk about their sensory characteristics or differences?
Either or both of those. Yes.
Oh, interesting.
But it can be very, very useful. I think Diana Henry, one of the other authors, has been sort of piloting that kind of use with the adult form, and she's already got some really very interesting cases where the partners had been experiencing some tension, and the discussion from the SPM helped them to realize, oh, it's because this kind of thing really does bother you. I mean, that sensory aspects really bother you. And now we're appreciating, this person just hates to be touched. The other person wants to be touched
Right.
and held and hugged a lot. And so they're feeling frustrated and a little annoyed with each other, but you can have then this discussion of, it's not that one's right and the other one's wrong, but they're just different ways of experiencing that sensory element. And can you come up with some strategies where both people are going to be happy?
Right. And that they can at least communicate that in the moment. When I come home from a long day of work, I'm particularly stressed. So I
Yeah,
need, quiet time or whatever that might
absolutely.
be.
Absolutely. And don't touch me. And
Yeah.
don't take it personally.
Please don't play the music loud because that drives me nuts.
I can't take it.
It's
Yes.
a personal experience. So that reminds me, though, in the school version, you had the different context within school of the cafeteria, the bus driver, the
Yes.
arts and crafts, the gym teacher. Do you still have those features?
Yes. Yes. We will have that for the preschool and the school age for sure.
Yeah. No, because I
Yes.
always love those, and specifically because those were a great way of encouraging team interaction within the school environment, so that you really had everybody understanding what was going on in this child and be different from one classroom, experience to, another teacher's experience.
Yes, absolutely. And it's such a great way to educate teachers,
Yeah.
because most of them really don't have a background in terms of the impact of sensory experiences on how we're functioning in different environments. And so it's a way to really help them appreciate, hey, this child really is having difficulty with the sensory aspects. And you can educate and maybe just lead to new insights that this might just remind the teacher of some other things they've been wondering about. And you can have a discussion then about sort of empathizing with how the child might be feeling, but then how can you then modify the environment or the routines, the classroom routines, or playground or recess time, so that this child's going to be more comfortable and more successful.
Yeah. It makes me wonder whether whether enhancing the knowledge of a teacher about sensory processing and integration differences would impact the way they might respond, even if it's specific to one student, if they're filling out the form, if that would enhance their ability to use that tool versus a teacher who might not have as much of a background.
Yes, yes, you would hope that it would really help that teacher to develop a broader knowledge and ability to empathize and have insight into how best to help. But that's where you need to have really the trained professional there to guide them and to give them information.
Yeah, I think so. So tell us a little bit about how the differences in the features that you would highlight. Obviously, the expansion of the age group, and certainly the adolescent and adult being able to fill out on the same individual.
Right.
Are there any other things that I might be missing?
No. Well, but we really tried to keep it as similar as possible to the original form. So it's for people who have already been using the original SPM, it's going to be very easy to pick up the new one, because it's structured very much. It was sort of like, well, it's not broken, so we don't need to fix it.
Yes.
We have the T-scores, it's all aligned. And I do appreciate the graphic design department of Western Psychological Services, the publisher, because they do such a beautiful job of the layout, really easy to use,
Yes, and
very
it's
clear.
it's very user friendly when you're showing it to a family or to a teacher, so that they can visually see where this child is at. And then when you're comparing the two forms, I always like that, because you can really automatically point out, oh, this is, this body awareness thing is really different at home versus at school. I wonder why, that is.
Right, right. And then investigate and discuss what could be going on.
Right.
Yes. Something else wanted to mention, as well, is the for the adolescent form, the authors were really concerned about making sure that the self-report, where the adolescent's reporting on him or herself, that we were wording the questions in a way that wouldn't be offensive to the adolescents. And we were particularly sensitive to mental health issues because we want this instrument to be able to be used easily in a mental health population.
Right.
With adolescents. So we actually had, I think it was 4 or 5 experts in adolescent mental health review every single question on the self-report form for adolescents. And they picked up things I would never have noticed. Don't use this word here. This is going to just make them angry. And they'll misinterpret this, or they'll think you have this agenda, which we don't, So the reviewers were very helpful.
Yeah, that's great. That really does make a difference, because so many of those adolescents or young adults oftentimes carry coexisting mental health conditions, or sometimes they could be misdiagnosed if somebody hasn't seen the sensory piece of what might be part of their puzzle. So that led me to be thinking, so on the school form, you had the social participation scales, which I personally was one of my favorite features, because it allowed for comparing or including some of the outcomes of intact sensory integration and processing that supports function. So I was wondering, is there an equivalent that you created for the adolescent and the adult?
So there's a separate social participation scale. So thank you for reminding me to talk about these. And then there's it's really a praxis measure, the planning and idea scale.
Okay.
So for children, actually a lot of the items are about play, what the children do in play, and whether they are able to participate in certain kinds of activities, for example, that involve sequencing. Some of them are self-care activities. But then ideation. Does the child do the same thing over and over and over? Or can they come up with a new way to do this, make a change, or a completely new activity? So we try to ask about ideation there. So there's that scale, which is measuring the ideation and motor planning aspects of praxis.
Right.
Okay. And it's distinct from the sensory scales. Okay.
Yeah.
And then we also have social participation. Actually, I've been really happy with that scale, because it turns out that, let's see, I think for preschool, and I believe also for school age, it's something like 8 questions. And with the 8 questions, they actually have very strong validity and reliability, and they give very meaningful information. Oftentimes, people will misinterpret this as this social participation scale as a measure of how sensory functioning affects social participation. Actually, that social participation scale solely is intended to measure social participation.
Okay.
So the questions aren't worded to where they're asking about sensory components. You get that on those other scales.
Right. So then you can associate the sensory scales, which are looking at modulation and perception. Is that correct?
Absolutely. Yes, absolutely.
And then you have the, is it balance, which sort of reflects the postural component?
And vestibular processing, yes. And it does include postural control.
Yes, yeah. And then your
absolutely.
planning is the practicabilities.
Right, exactly. So because the social participation questions on that scale aren't dependent on particular aspects of sensory processing or on praxis, you're getting kind of a clean picture of just how well can they participate in, for example, going with the parent or caregiver to run errands. Can parents rating, can I take that child with me, or is there a meltdown every time? Now, it's not, if there's a meltdown every time, which the parent would have to be telling you, right? As you go over and do the interview, looking at what they checked off, you're going to be looking at those sensory scales and thinking about how, what we're seeing here, how is that contributing to the social participation issue? But it is certainly possible to evaluate a child where there's a social participation problem, but everything else in terms of sensory and praxis looks okay.
Yeah, that's what I was thinking. And that's really good to rule out when a kiddo, not that they don't necessarily need occupational therapy, but that their therapy intervention doesn't necessarily focus on sensory integration strategies or tools.
Right.
Yeah.
Exactly. Yeah.
That's exactly what I was thinking. Now, I had one other question because I remember with the initial SPM, there was a recommendation, I think it was in the manual, about looking at items, looking at the sensory domains at an item level if you
Yes.
wanted to tease out, and I think if I'm saying it accurately, to tease out differences in modulation versus perceptual challenges that might be affecting the child's function. Is that still the case?
Yes, absolutely. We're using that same kind of model. And in fact, there's a table, and there's a caveat attached to this. There's a table that lists each item in the SPM or SPM2. And here is some of the underlying sensory issues that this might involve, or praxis issues that it might involve, or most often. But you still have to use your clinical reasoning, because it could be that this is a unique case and it's not what's on the table. So the table kind of gets you thinking about what's probably, let's say this question, sounds to me like auditory hyperreactivity. Okay, most likely is, but you need to just check to be sure there isn't something else going on, so you always want anything that looks like a problem area is ideal and strongly recommended that you follow up with the respondent, whoever filled out that form, to let's discuss these and how does this look. And if you see something that looks really maybe in conflict with what you're observing, you definitely want to spend some time sitting down and talking about that.
And,
So,
I think that's a really important piece to convey to people who use or who rely a lot on parent report measures, that this kind of follow-up conversation around the issues that come up in the form isn't really just a luxury that you engage in, because I feel like you have to really understand the perspective of the parent or the teacher, why they may have gone in a certain direction in the way that they answered the question. And I know it's time consuming for the clinician to do that, but sometimes those discrepancies between context, or even if you've then done some kind of performance assessment or some clinical observations in your therapy clinic, and you see different things coming up, that pulling it all together in that comprehensive assessment really has to involve the parent and or the teacher if possible.
absolutely, yes, because you have to keep in mind always that what you're gathering is information about the perceptions of the person who filled this out.
Right.
Okay, and what is it that's informing them? How are they thinking about this? And I want to give you a little example. This is from my colleague Cheryl Ecker, another author of the SPM, who um, administers a very large private practice in Southern California.
Yeah.
And in one of her cases, the child on the SPM looked like everything's fine. And then when she brought the child into the clinic area to watch her interact with the equipment and other children, she saw some things that looked definitely like significant sensory issues, and followed up. They ended up having to rescore the SPM, because let me give you an example of an item. The question was something like, a child dislikes being in bright light. I don't know the exact wording, but it's similar to that.
Right.
And the parent, no problem, never has a problem. Well, when Cheryl did the follow-up interview, going item by item, tell me what this looks like at home. Can we talk a little bit about when this happens and how it occurs? Well, it turns out the child didn't have a problem because she would never go outside without sunglasses and a hat on.
Right.
So the question then was, well, what would happen if she went outside with the sunglasses? Well, she just wouldn't go. She wouldn't be able to function. Okay.
Right.
So then you rescore. And there were many items. What had happened was I think the parents had adapted very, very well to the child's needs, which is
Yeah.
what you need to do as a parent. And apparently the difficulties had persisted and were getting a little bit more significant with age because the child had been referred for the individual therapy.
Yeah, that's exactly what I mean. Parents oftentimes don't even know how much they, help the child accommodate and adapt their environment to their sensory differences, and support them until a kind of situation like that exists. Is the scale going to be sensitive for use as an outcome measure, a pre-post measure? Do you know?
That's a really good question. For years I have been always erring on the cautious side, saying, well, we don't really know. I don't know, it could be. And it's true that there can always be bias. Let's say you're hoping a therapy is working, and so you're going to be biased. Actually, let's see, my colleague, I was thinking, what is the study that sort of tipped me over into saying, yeah, I think we can use this as an outcome measure. Cláudia Almairi in Brazil replicated Roseanne Schaaf's randomized clinical trial. Okay. And she replicated it in Brazil and used, in her study, she did use the SPM as one of a number of outcome measures. And it did seem to be consistent in showing gains similarly to the other outcome measures. So I am feeling optimistic at, hey, it probably could be used as a meaningful outcome measure. Although keep in mind, we're asking the adults or the people who are self-reporting for older age groups now, they're going to be thinking back over the last 2 or 3 months. Okay. So you just want to remind them to just think about that, not sort of all the time they've known the person, but the more recent.
Yes, that's a good point.
Time. Yeah.
And it may be that, I mean, although we don't know this, would it be more sensitive, several months out past the completion of therapy when hopefully those changes have solidified in terms of the child's life and the parent's perspective on their child's life?
Yeah. Actually, that would be a great design for a study where you have a pre-therapy, pre-intervention evaluation data. Then you have immediately at post-intervention, and then a third wave out there of a follow-up. Yes. As you suggested, 6 weeks or 2 months would be a pretty good time frame for that. That would be really interesting.
Yeah, great. I know. I've always wanted to follow beyond the time that it's in therapy. Well, we're kind of running out of time, but I want to make sure that we didn't miss anything that you want to share.
So one thing I think is important to keep in mind too about using the SPM is that ideally it's just one component in a comprehensive assessment. So the more sources you can use and different types of assessment tools, the stronger your assessment's going to be. So in that evaluation process, the ideal, in my mind, the ideal is that you do an interview. You might use a standardized questionnaire such as the SPM. You also use a performance test where you're actually asking the child to perform tasks. And then you're having normative data to score. Now, SPM is normative data too, but it's such different information. It's the perceptions of someone who knows the person best, or maybe their self-perceptions. So it's very contextualized in everyday life. The performance tests are decontextualized from everyday life because it's a little artificial, right? You're asking, children to perform things that maybe they don't do in everyday life. It's still very, very valuable. It's going to give you information that the questionnaire is not. Okay,
yeah,
so I think strong normative data, they're both valuable, but it's great to have this more comprehensive picture.
Yes, I totally agree, and I do think that in school-based practice, having a tool that the teacher can utilize, and then maximizing the therapist's time in the school, which I think is always way less than what is ideal, but they have to function within those parameters. So if they only have 30 minutes, at least they have another source of data from the teacher, hopefully also from the parent, and then from their own time with the child. And those standard scores are also really useful when reporting data to funding sources, whether they be the school, being in the school versus from the insurance companies.
Yes. Yeah, absolutely.
Well, thank you on behalf of me and Star for taking the time and sharing all this wonderful information with us.
Thank you, Sarah. It was fun.
Yeah, I told you it would be.
Yes, you weren't kidding. It really was. It was nice. So thanks so much for giving me this opportunity to talk about the SPM too, though.
Oh,
Appreciate it.
absolutely.